Aloha, my name is Josh Green. Welcome to Healthcare in Hawaii, physician on the Big Island and senator from Kona. Today we're going to speak about the healthcare workforce challenges we have in our state. Our show is entitled Hawaii's Healthcare Workforce Challenge, or the Hawaii Challenge to get physicians here in our state working, which is what Kelley's been working on for years, it looks like. I'm joined by Dr. Kelley Withy, who has got an MD from San Diego, PhD from UH, went to Harvard before, she's terrific, and runs AHEC, which is the Area Health Education Center, professor at JABSOM. We've spoken before, Kelley. Thanks for being here again.
Sure, my pleasure.
So we hear a lot that we have a physician shortage here in our state, and I know that you've been a point person on this. It's a great challenge, but you've convened all the people in the state to look at this problem. Why don't you give us a little bit of a historic update and where we are today?
Sure. Well, in 2010, David Sakamoto and I started looking at the workforce. Mayor Harry Kim helped us out to start, and the Board of Medicine here helped us by allowing us to do a voluntary survey. We, at that time, estimated we had about 3,300 physicians and needed about 4,000 some, so we were about 500 short.
Mm-hmm.
Since then, we've had a couple different modeling methodologies for demand, but it looks like right now we're still over 500 short. We're between 600 and 800 short of physicians across the state. We now, well, he retired, but now I'm looking at it, and about 700 of those are 65 or older this year. So about 20% of our workforce is retirement age, although we tend not to retire then. So we have shortages across the board. Mostly on the worst is the Big Island, as you know.
Yes.
But rural areas of Oahu, all the neighbor islands are all short. Even Honolulu has shortages of many specialties. Primary care is the #1 demand, unmet need as far as numbers of people.
Right.
But we have specialties in surgery, orthopedics, anesthesia, cardiology, GI, ID, all kinds of specialties.
Now, I'm so glad to have you here on the show because we've had these conversations over the years, and I do know that it's a great challenge, not just to find doctors, but to even characterize the shortage. You've described one of the challenges to me, if I'm not mistaken, that some people from the outside, oh, Hawaii's not short on physicians. You have all these licensed physicians. Yet the reality is we have far fewer practicing physicians. Could you unpack that a little bit?
Sure. We have over 9,100 licensed physicians. Some of them may be military, because military you only have to license in one state. You can practice wherever.
Yes.
We don't know how many exactly are military, but maybe a few hundred is my guess. But we only have 3,600 practicing non-military providers.
Okay.
So we know that we have about a third of the number that are licensed practicing. Some of the national estimates look at number practicing, but it's hard to find. We go very in detail. We actually call offices and say, is Dr. such and such working there, full-time or part-time?
Right.
So we do more detail work than national organizations. A lot of national organizations ask for a survey every year. They might get it, they might not get it filled out, so that's what they go on, and the licensure numbers. So we're more detailed. We know we're about 95%, we estimate, correct.
Got it. Yeah, so you've drilled down not just to the number of licensed physicians that are practicing, but you've even gone further. You've gone to the number of FTEs or full-time equivalents. Explain that a little bit, because I was trying to explain that to someone ineffectively the other day.
Okay, so if I'm a teaching physician, but I only do 1 day of clinic per week,
Yes.
I am a 0.2.
Okay.
So I'm 20% of a full-time equivalent.
Got it.
If you're working, like I know you are, 80 hours a week,
Yes.
you're only 1.0. Sorry, you only get 40 hours credit max.
Yes.
So that's how we estimate. If somebody is 1 day a month in Kona,
Yes.
for example, then they would just be that equivalent on a weekly basis.
Got it.
So we register, we document all their offices, and we try and put how many hours they are in different offices.
So you're able to then say, we have this many people in the state of Hawaii. Based on normal demographic needs, we should have this many doctors. You know exactly how many we have, and that's how you determine how short we are.
Almost.
Okay.
So the demand modeling is very difficult, because in a perfect world, we would have more than enough for everybody.
Right.
So we don't do a perfect world model. What we have is the organization who does this for the federal government, who documents demand, basically, is called IHS Global, and they take the national picture of how many physicians there are in each specialty, and they've made a little micro simulation of Hawaii. So we have 1.3 million people. Our ethnic mix is this, more or less. Our gender mix, our age mix, our insurance coverage mix, our obesity rates, our diabetes rates, and they made a little model for each of our counties in Hawaii. And then they take that model and they apply it to the mainland, all the U.S., including Hawaii, and they say for this mix of people, averages, you have this many surgeons and this many family docs and this many cardiologists.
Yes.
And that's what we use. So it's not a perfect model, it's the average US for our population.
Okay.
It's what we're using now, but there are many instances, for example, psychiatry. We know we need more than there are in the average US.
Yes.
I mean, we have shortages documented on the neighbor islands, but even on Oahu, we know we don't have enough. So how do we figure that into our model? It's difficult.
It's also, isn't it complicated additionally by the fact that we have a very large population of Medicaid individuals? We've talked about this on some of my shows, and I'm really curious about your opinion on this. Hawaii has about 335,000 individuals that are on Medicaid, and not all providers will take Medicaid. For instance, on the Big Island, it's over half of the patients now are on Medicaid. So this last weekend, I did a 3-day shift, so that was 72 hours. And I would say the heavy majority of my patients both were Medicaid and didn't list a primary care physician. So there may have been, say, a psychiatrist, I don't want to pick on one discipline, or an internist or what have you in the region, but they weren't taking any additional patients that had that class of insurance. Wouldn't that also end up kind of seeming like a physician shortage, even if there was someone there?
It would definitely feel like a physician shortage. If you can't get a physician, there's definitely a physician shortage. I believe it's 67% of our doctors say they take Medicaid.
Yes.
That may just be one patient a year. It's hard to differentiate from, how many, and we don't do that. So yes, that does complicate things because Medicaid is perhaps harder to bill for.
Yes.
I mean, there's 5 different Medicaid insurances. You have to have different prior authorization requirements for each one, different payment methodologies, all kinds of different demand by the insurance company. And it pays lower in many cases. So a lot of doctors choose not to do that. Some are even choosing not to do Medicare.
Yeah.
So some are choosing not to do some of the private insurances. So finding a doctor is twice as hard because you have to find one that takes the insurance you have.
So what you're describing is coming out of the gate, big picture, we have a shortage of over 600 physicians. We're short. Then on top of that, you lay the complexities of the modern healthcare system, whether someone takes this insurance or that insurance, whether they live on an island that has this discipline or not have that discipline. You add all these things together, and often for our patients, it's very difficult to find a provider.
Extremely difficult, especially on Big Island and the neighbor islands, because they may have to fly to Oahu, and that's very difficult to schedule as well, especially if they need a caretaker with them. I won't even go into that, but you know what it's like.
I do. I'll tell you the experience that I have, which is a bit of it's a singular experience as an ER person, because you see everybody that comes through your door. That's a plus on the one hand, because people know they will be seen by a doc and I will do everything I can to help. However, my resources are limited. Then I have to find someone who's willing to take the patient at the next level. And if it's not a very serious problem, if they came in for a basic problem, it's almost impossible for me to find someone to refer them to help them maintain their care. If it's a very serious crisis, then I can find someone. For instance, this weekend I had a young man, 18-year-old, who came in with terrible leg cramps, fever, and so on. It turned out to be leptospirosis, and he was having complications from this leptospirosis, and he was having renal, it was affecting his kidneys, he was in liver failure. He was going to die, actually, but the teams at North Hawaii and Queens leapt to my aid, and they were terrific, and thank God the kid's doing well as of now, and hopefully well going forward. So in that emergency circumstance, I was able to get infectious disease support, internal medicine support. Had I needed an immunologist, I could have even had someone because he had big challenges. But if he was just kind of okay, he would have been almost on his own. And I assume that that's a problem you see a lot of the time.
Oh yeah, even on Oahu. It's hard to find doctors to refer a lot of patients to. So on the neighbor islands, it's even crazier.
Yeah.
And some insurances don't pay for the transport to Oahu to get the services. I would say telemedicine would be a good option, but we are not employing it adequately here.
I want to get to that. I'm definitely going to ask about that. Before we do that, let's finish this line of thought. I'll tell you. Tell me what are the biggest challenges, the disciplines, the healthcare disciplines of greatest shortage in your estimation in Hawaii?
Primary care is always number one.
Okay.
As far as people on the ground. Then each island is a little different, but we have shortages. Cardiology, GI, surgery, orthopedic surgery, anesthesia that goes with the surgery need. We have infectious disease, but there are a couple of specialties that work really hard and compensate for their shortages. I would say infectious disease, GI, and pathology, very, very short, but folks work really, really hard, and so sometimes tell me, oh no, we don't have a shortage.
So they're willing to pick up the extra slack just because they either don't want competition or they're willing to take on the challenge or whatever it is, but because I have to say, usually in infectious, I got a cousin who's an infectious disease doc, and he'll take my calls and do a consult for me, as will the GI guys, Dr. Aloy, and those guys are great. But yeah, to schedule it sometimes is tricky.
Yeah, so we have a lot of docs who work twice as hard probably as they would on the mainland. But let's see, endocrinology, nephrology, I could go through all the allergies.
The specialties.
All the specialties are short. I mean, the only things that we're not terribly short in are plastic surgery and in some places dermatology. Radiology, it's hard to tell because we use a lot of folks from the mainland. So I wouldn't be able to tell you if there was a true shortage.
Sure.
But pretty much everything else.
So that's really interesting. So before we go to our first break, let's break down the why. From your experience, what are the key factors that have put us and maybe many other rural states in a situation where we have these serious challenges and shortages of providers, especially physicians?
Well, we don't train enough.
Okay.
If we could train them and keep them, if we could train 3 times as many as we train and we kept them, most of them, we'd probably be okay, but we don't.
And we love JABSOM. However, the class size is about, 66 or 70? 72. So you're saying in an ideal world, we love Dean Hedges, and he's been on our show a couple times. If we had the capacity to bump up to 200, we could be training them, because you've told me on many occasions, those who train here tend to stay here. But we have finite capacity. Even JABSOM can only house so many students, young medical students. Okay, so if JABSOM were a lot bigger or could train people more quickly, which is hard, we'd be not so short. What else?
Our residency programs. So if we were to train 200 medical students in-state, then we'd have to double our residency programs for 200 folks training in-state. We'd have to, I would really target in-state people, especially in the specialties we needed. And if we could train them where we needed them, like the Hilo residency program, that would be very exciting, because then they're there.
Didn't you tell me once that the number is something like 85% of those who train one way or another in the state of Hawaii will stay and remain as physicians here?
If we train them in medical school, a little over half stay. If we train them just for residency, a third to half stay. But if we train them for both medical school and residency, 85% stay.
Wow.
That's what we want.
So that's our goal. So we want to encourage young people who are coming either out of Manoa, or maybe they went to the mainland for college, but they're coming home. We want to lock them in med school, lock them in residency, and then they'll be our doctors on Kauai or Big Island or Oahu, but under any circumstance, they will decrease that gap. Okay. What other challenges do we face?
We have low pay here in Hawaii, and so whenever I'm on the mainland, I say, oh, we have plenty of jobs in Hawaii. Doctors' eyes perk up. And then they say, oh, what's the salary, what's the benefits, what's the cost of living? So salaries are low, cost of living is high. Very discouraging for people to move here. We also may not have the schools that they expect for their kids, the jobs for their spouses. We don't always do a good job of welcoming our new providers and their families. And then a lot of times they leave for family reasons. They have ill parents. We lose a lot of people for that reason. That's why if you grow up here, way better. Everybody's here.
There's that. Yeah, that's the reason, really. Because for me, my family, I came with a National Health Corps scholarship, so it was a great opportunity. I met my wife here, as you know. However, I've gotten into other things. We'll never leave. But now I have to have my mother move over here, eventually my father move over, because they're up in their 70s. And sooner or later, Mother Nature comes calling. We're at 15 minutes. Why don't we take our first break and we'll start working on some of the potential solutions for the problem.
Okay.
So I'm Josh Green, Senator from the Big Island and an ER physician. I'm joined today by Dr. Kelley Withy, who's an expert on the physician shortage. Thanks for joining me.
Aloha, I'm Kelley Withy, president of the Grassroot Institute and host on Ehana Kako, a weekly program on the ThinkTech Hawaii broadcast network. Ehana Kako means let's work together. Think of the sad alternative, let's not work together. Here in Hawaii, with all of our diversity and the richness of the people, it's important for us to come together around issues on the basis of what's right and what's good and what's going to serve the common good. And that's what we try to do at Ehana Kako. Every week we interview movers and shakers, people in government, business, and other sectors of society to talk about how to create together a better government, economy, a better world here in Hawaii that can bless the rest of the world. I thank you for your attention to ThinkTech Hawaii, and we look forward to seeing you every Monday, 2 to 3 p.m. on the ThinkTech Hawaii broadcast network. We're Ehana Kako, and we wish you well. Aloha.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green. Today we're talking about Hawaii's physician shortage, and I'm joined by an expert in this area, Dr. Kelley Withy. She's got her MD and her PhD, and she runs AHEC. She's terrific, and she has really provided a lot of analytical time and experience on this problem, so she's the go-to person in our state to tell us how short we are on physicians. In our first segment, Kelley, you were able to tell me we're about 600 plus docs short. We've been pretty stable in this shortage, which is both discouraging and discouraging. We haven't gotten worse. However, you've told us also we have over 700 physicians that are 65 years or older. So we're in trouble if we don't bring more physicians here or train more. We had a comment from one of our viewers, and this viewer commented, does this mean, because of one of our earlier comments, that more of today's doctors are motivated by finance more than healthcare? They said, can't imagine doctors are going broke. This is something we hear a lot. We say that the reimbursements or the pay is lower in Hawaii, so it's hard for us to outcompete California or Texas or Pennsylvania. What's the reality on that?
Well, when I went to med school,
Yes.
and it was about 20 years ago, it cost me $2,000 a year.
Okay.
State-supported school. Now, even the state-supported schools cost $30,000 to $60,000 a year just for tuition.
Got it.
And then you got to live on top of it. I'm not sure how this happened. I mean, we've had escalation in all our educational costs. But that means that doctors come out with $250,000, $300,000 in debt, even at a state school.
Right.
Unless they do military service or National Health Service Corps like you did,
Right.
they've got a huge burden.
Right.
Starting doctor starts a little over 100 probably out of
Mhm.
residency, so that's 7 years at least after college. If they're looking at huge debt, they're not going to take maybe the specialties or the jobs where they're really needed. They're going to take the high-paying ones. So I wouldn't say they're motivated by money, because when you ask them what's the most important thing to you, it's a good work environment.
Yes.
But they are thinking about it because they have such big debts.
Yeah, I think I've told people that before. I mean, my first real job was at age 30. And I don't want anyone to ever complain or worry about me, but at age 30, I had $140,000 of what would have been accrued debt, so I paid it back. But that took me to KAU, where I was probably the lowest paid physician in the state. And I was honored to be that person working in KAU. But had I had a couple kids already at age 30.
You already had a house mortgage, essentially a house mortgage on your back before you even got a job.
So it's harder, and again, I wouldn't think that the physician would complain. However, if someone had a different opportunity in a different state, I think that's what we're saying, that paid 3 or 4 times as much in either a specialty or a higher paying environment, they might go there to pay down their loans or to start their family. Isn't that what you're kind of describing?
It is, and they leave here for that reason. I mean, we just had one leave. We were giving him loan repayment. It ran out, and he said, I can get paid twice this much on the mainland. I got to go. I got 2 kids.
Yeah, so this brings us, that's a very good segue. You and I have spoken about loan repayment. You seem to be a believer in it, as am I. What would that do if we were able to finally get the resources into a fund to do loan repayment for, say, primary care physicians or even specialists? Would that make a difference, do you think, to bring doctors to Hawaii?
Well, this is one of my favorite topics, as you know,
Yes.
and one of yours.
Yes.
We actually have a federal grant for $250,000 a year of loan repayment, but we have to match that dollar for dollar with local dollars.
Right.
And we struggle to get those.
Yeah.
We go to insurance companies, we go to Queens, we go to the health centers, and we beg for that match because we can pay $30,000 to $40,000 of a physician, nurse practitioner, social worker, psychologist, physician assistants loans
Yes.
down directly to the insurer or the bank.
Yes.
So no tax implications, and they love it.
And we lock them in then, and then we outcompete these
have
other
to,
states.
Right, so they have to be there for at least 2 years, and then we go on a year-to-year basis. And a lot of our we have 18 people we've helped.
Yes.
A lot of them had $250,000 in debt or more.
Yes.
Some didn't, and they're very happy. They're done with
Yeah.
their debt, and they're thrilled. But a lot of them stay where they pay off their loans or in the area. Some of them don't, but they have to be there for at least 2 years. And so it's an immediate way to get a provider
Yeah.
into the area you want.
Yeah, and it's a nice way to do it too, because I think I guess I'm referring a little bit to that viewer's question or observation, but I haven't really come across a lot of doctors that say, boy, I want more salary and more money, but I think that they want to be here in Hawaii. Many of them have a strong tie to the islands through loved ones or some other experience, but without putting too fine a point on it, just to get rid of that debt, they would be more than happy to stay and put all other economic concerns aside. So that's something we have to continue to really fight on. And I think it is important to mention it because it strikes people as surprising or ironic that is an issue. But once people see that, number one, it's $250,000 in debt very frequently, and also, remember, most people have a job in their 20s. Like I said, my first
Right.
real job, I mean,
Me
I
too.
worked as a waiter, and I worked
Yeah.
as a volunteer in a lot of different places, and I worked in a lab for minimum wage when I was in med school, but I never had a paying job, a significant paying job until my 30s because I was still in training. And that makes it very challenging. And I was trying to take care of a mother and a younger brother and whatnot. And a lot of people do have kids during school. So
And you're not allowed to work during medical school.
Yeah, I know.
And then in residency, so you come out 4 years after
med school.
after high school. So 4 years after high school, you graduate medical school. You might get paid $50,000
Yes.
for your first at least 3 years.
Yes.
And then, starting salaries here, I guess, their primary care, I'd say 120 to 150 maybe, and that sounds like a lot, but when you're paying off, I don't know, you probably have $3,000 in loan every month.
Yeah.
That's post-tax.
Well, it's very helpful because, look, that's what I do tell people. We'll move on after this, but $150,000, a fantastic salary in society, but $50,000 goes to taxes, that's $100,000, another $40,000 to your loans. So then you're at $60,000 while you're working 70 or 80-hour weeks typically, and you haven't yet bought your first house, and you're probably looking to start a family. So it is a challenge, but also you had a 10-year gap where you didn't work.
Yeah,
So
no savings, no nothing.
right, so you divide those again in half, and so that is the challenge. But we won't cry for doctor salaries, but we will try to recruit them and find a way.
Right, and the fact is it's not that they won't come here because of the money.
Yes.
The money's okay, but there's so much better pay elsewhere that they'll leave here easily.
So we need other models. So we talked about loan repayment. That can definitely bring doctors. Look, it brought me here, and I stayed, and I kept my life simple, and so I was able to stay. After loan repayment, what other kind of initiatives or strategies would you employ to get doctors to come to Hawaii or be in Hawaii?
Well, I say first we keep the ones we have.
Yes.
So we keep them happy. A lot of that involves the medical community. We've gotten a little alienated now we have hospitalists, which are great,
Yes.
but now our docs don't go to the hospital, so they don't see each other very much, so they're isolated.
Yes.
So we need to kind of help that community happen. And it is happening on the Big Island.
Yes.
The mayor thanked all the doctors for their service. But I always like to tell people, when you go see your doctor, just say thank you.
Yeah.
It's free, and you're lucky they're there.
Yeah.
So anything that's the most important things to doctors, actually getting appreciation and feeling like they're doing good. That's what they really want.
Yeah, and there are a lot of times I think people don't realize it, and this is not to have a pity party for the docs, but they have stresses like every other person, and they tend to overwork themselves, especially in a climate where we have a shortage. They're very loving, compassionate people usually, and they So they're working those extra hours, and they're dealing with the bureaucracy, which they hate, like we all hate, with the insurance industry and others. So they get frustrated. So when they hear something, I know this is true for me, when someone says something nice after I've sewed them up or if I've treated their pneumonia, boy, it really kind of lifts you up. And that was always made it easier for me to come back for my next 24-hour shift when I had a good shift that has just passed. So that's a great thing to do. What other things do we have to solve? I mean, you said earlier, like schools and jobs for spouses. Is that possible to help?
Well, we could have a dating service for doctors.
There we go.
That's probably unethical.
Now our show is going to verge towards prostitution.
No, I think that's a bad idea. But there are things we can do. The insurance companies could simplify all the paperwork.
Yes.
So I had a high school student do a little internship with me. I had him pull every prior authorization form in Hawaii from the different insurance. We only have 8 insurance companies. There are 550 insurance or prior authorization.
So it should be simpler in Hawaii because California's got 50 insurers probably.
Yeah,
we
exactly.
have 8, and really HMSA represents about 3 out of 4 individuals insured. So it should be easy, but it's not.
It's not. So there's so many regulations, so many forms to fill out, so many things that are blocked, and you have to go back and redo things. It's very frustrating for physicians across the country. This is not unique to Hawaii, but it's incredibly frustrating right now. You have to hire a person just to do this.
Yes.
So there's part of your.
Yeah, that's an interesting thing. So, and that adds extra cost and overhead where we'd like to be providing more healthcare services. I mean, I'd like to see us having more nurses and aides and people that are in public health. Instead, a lot of the times we're forced to hire more administrators, and they're terrific people and bust their butts, but they're really just handling just the basics to get you in front of the patient and to get that patient in front of a specialist or they get their tests, when it seems like we're such a contained, small society, a healthcare society here. We shouldn't have those barriers. And we keep bringing it up, but I guess we're going to somehow have to penetrate the psyche of, you know, the kind of the bigwigs at HMSA and Kaiser and all these places, because the other day, I'll give you another example. So I was transferring a patient. I had an individual that needed to have psychiatric help, and I called the person was pretty young, but she did qualify as an adult. So I called her primary care provider. They were unavailable because it was Saturday night, so I understand. Then I called one hospital, and I had one conversation with the intake person. They took all the information. Then they had to call the psychiatrist that was on call. Then they told me that I was outside of that region, and I'd have to call the other region. So then I called the other region. The other region was full. And they would only take the patient to the ER, but the ER wouldn't take the patient unless it was accepted by a psychiatrist. So then I called a care coordinator. So this is now the 5th call. In a pretty sick young person, very wonderful young person, but needed real help. They had attempted to hurt themselves. I next called a care crisis coordinator, and we were having a flood in Kona. So it took 5 hours to get them to the patient. Now it was middle of the night. They did come. They did provide good care, but all those hospitals were still unavailable. And now I was into 4 or 5 hours of administration trying to care for this one patient in an ER setting, when really what they needed just was to talk to somebody. So you can imagine how frustrating that is for the patient, but also for the healthcare providers who really wanted to do something but couldn't in that case. And that's over and over again.
Let me take it a step further.
Yes?
Where did that person go when they left? Did they go home?
Ultimately, they went to, 2 days later, we were able to get them into a short-term transition safe house.
Which is great,
Yes.
because we usually don't have that option for
Right.
people. So they may, if they're admitted to the hospital, they're then just discharged home.
Yes.
And the family has to figure out what to do, and they're not trained or ready for that necessarily.
Yeah.
And so the burden is put on them because we don't have enough beds.
Yeah.
I just finished some focus groups on Big Island, and it's obvious across the state we don't have enough beds for psych patients.
Yeah, see, so these challenges abound, and I think that it sometimes surprises the community at large. Why is it so hard to see a doctor? Why is it so hard to find someone that's willing to care for me or my loved one? And they're all there. And I even had an interesting back and forth with a person the other day. As you might have read in the newspaper, we were talking about the cost of transport, air transport. Now, it is probably too expensive, and I know they do great work, but people said to me, well, why don't we have a full complement of trauma services on each of the islands? And I tried to explain, well, we want them, but in a population, for instance, take Big Island, we have about 220, 230,000 people, but 2 main population centers, Hilo and Kona. neither is large enough to support a full trauma team. In fact, even together, they're probably not big enough to have a neurosurgeon, a full trauma team, full anesthesia, all the other services that necessarily go with a level 2 trauma center. So we sometimes have to do our best to stabilize the patient and then transport them. But it's even more challenging if you imagine when you're on Lanai, where there's very few people, or in Kauai, where maybe there's 60 or 70,000 people. So we have to be prepared in Hawaii, not just to deal with the physician shortage that you've described, but to deal with the very natural, challenging demographics, because you're really, for the most serious challenges, you're only going to have all of those providers on Oahu, unless you're darn lucky. And I assume that that's another phase of the problem for you.
Oh, yeah. Definitely. I mean, small areas cannot support the full team that you're talking about, and yet that's what we want.
Right.
So either we pay for that team, which is very expensive, and the hospital facilities to serve that team that team needs,
yes,
or the services just aren't available.
And before we go to our next break, I would even comment that it is even arguable. I mean, it's worth having this debate at some point about whether you want a team in a rural place where they don't have as many cases, because if you're the trauma team in a very rural spot and you don't have a lot of cases throughout the year,
you need to stay up on it.
You might not be as sharp.
So we would have to rotate them around.
Yeah.
Yeah.
So big challenges. Let's go to break and we'll come back for our last 15-minute segment on the physician shortage in Hawaii. I'm Josh Green, your host of Healthcare in Hawaii, joined by my guest, Dr. Kelley Withy. Thanks for being with us.
Hi, I'm Donna Blanchard. I'm the host of Center Stage here on ThinkTech Hawaii. Center Stage airs every Wednesday at 2 o'clock, and of course you can check out our archives on YouTube or on ThinkTech Hawaii anytime you like. Why should you do that? Because this is an arts show that I believe is making a difference in lives. We talk with artists of various ilk. We talk with painters and writers, playwrights, novelists, poets, sculptors, dancers, you name it, directors, actors, of course. And we don't only talk about what people do, but we talk about how they do it. And my favorite part of the conversation, we talk about why they do it. And it's really common on this show to hear people say, wow, I didn't think about it that way. And it's very common to hear people afterwards who have seen the show say the same thing. And I hear all the time that people are inspired by the conversations that we have. So why don't you join us and be inspired too? That's Center Stage on Wednesdays at 2 o'clock. We'll see you Center Stage.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island, Medical Director at the Hawaii IPA, and I work in the ER. I'm joined today by Dr. Kelley Withy, who has both an MD and a PhD, and she treats patients. She is a leader at JAPSOM, and she's been working on the healthcare shortage for the last 5 years, really putting the numbers to the problem so that we have an analytical challenge that we can then put practical solutions to. So Kelley, you've described that we have this shortage. It's been well described that we're 20+% short across all disciplines. We're short on primary care providers, we're short on all the specialties, and we're particularly challenged on the neighbor islands. We've been kind of flat. You told me before the show that we have about the same number as we did last year, which is both tough news because we'd like to see that number increase, but it's also good news that we haven't plummeted. But what are the solutions? I mean, what's going to have to happen in our national healthcare picture and really here in Hawaii if we want to start taking care of all of the patients that we have?
Well, we already talked about training more.
Yes.
We already talked about loan repayment, get them where you want to go.
Yes.
The other things, there's lots, of course, but working in a team, so taking off some of the burden from the physicians,
Yes.
would be really nice.
Now that's an interesting comment that you make. We've had people on the show before that talked about patient-centered medical home and working in these team-based settings. That is kind of changing the face of healthcare. That means, if I was going to unpack it and interrupt me and correct me here, that means that a lot of services will be provided in the future, now and in the future, by nurse practitioners, physician assistants, dietitians.
Going way past, yes, all that,
Yes.
but then community health workers, psychologists, social workers, all kinds of care coordinators. I
Yes.
mean, just a full team. But in our state, 58% of the docs are in small practices.
Right.
They don't have the capacity to hire a care coordinator and a community health worker and a social worker to do the things that you described just recently.
Yes.
So some of the big groups do it very well, HPH, Kaiser, Queens. They have the team coordination, and it's a
Right.
beautiful thing.
Right.
But how do our Marcus Welbys do that? It's very challenging.
And see, I think that it's so good that you bring that up, because we've had some people come on and talk about the Queen's CIPN, the Clinically Integrated Physician Network. We've talked about the Hawaii Pacific Health Physician Health Organization. So they're able to add those providers, and they're in partnership with.
And they have great EHR.
Yes.
That talks to other EHRs.
That's
Key.
electronic health records.
Yes.
So that's another part of the puzzle, to communicate so that we don't duplicate tests, or that we get people quickly to the right.
So you know what that kid's background was, you know his health history.
Absolutely, and it's interesting because a lot of the systems don't talk to one another. And I had an individual up at Koala Hospital, and a hospital just 30 minutes away provided great care, but our EHRs, electronic health record systems, didn't talk to each other, and the fax machine was down. So I had to just go with what I could. And I didn't know that this individual had or hadn't had the upper GI studies for her gallbladder. So I had to go based on physical exam. It would have been very helpful at that point to know, oh, she already had a CAT scan, she already had an ultrasound.
So you wasted a bunch of money and her time.
That's
because
right.
you didn't know. I've had to counsel a woman about breast cancer without knowing what her breast surgeon told her.
Yes.
I mean, these things we shouldn't have to do, but right now.
Yeah. And until the system changes and evolves a little bit, whether it's the Hawaii Health Information Exchange, everyone's trying to put that together. Big challenges, probably for a different show. We've had Christine on the show before, and she's due to come back, actually. Until that's all sorted out, we're going to have to kind of work as a team best we can. But I was going to ask you, do you think that looking forward 10 or 15 years, that when you go to see the physician, you actually may very well be going to see the nurse practitioner backed
Your
up by the
team.
physician. So you'll see the
Your
team, and that may work very well, but a lot of times people will still want to see the doc. I can tell you, I'm a big supporter of the integrated model of the patient-centered medical home and the team, because it adds public health, it adds prevention, it adds a lot of sanity to the lifestyle. But I also am cautious, because I was able to diagnose a kid with leptospirosis the other day that many people hadn't seen that case before, and I had a little extra experience and a little extra time. All those long shifts and long training hours did help me in that particular case. I'm not perfect, but it had been glossed over for a few days in other settings, and so I'm not sure that people will always get the diagnostic support they need. We'll see. I think we're going to have to be very mindful of that. But I do want to say I totally respect and appreciate having nurse practitioners and these others
Everybody
as
should
part
be able
of the
to
team.
work to the level that they're trained and
Right.
not be forced to work beyond that.
Yes.
And the fact that doctors have tens of thousands of hours of clinical experience, and nurse practitioners and PAs aren't given that much. And
Yes.
so they do need to work in teams.
Until
And-
they're up in their career, and then they will
Yeah.
have that clinical
But I mean, but the
experience.
team goes past that. I mean, there's so many things to do in healthcare that you described. But just imagine going back to your trauma teams.
Yes.
What if, and we do have this in many areas, what if we had teleconnectivity to Queens for the advice for that? You know, what if we could get a lot of these services that can't get on Big Island through telemedicine?
Yes.
That would be, it's not perfect. You know, you need to have a relationship set up, you need to trust.
Yes.
You need to have a way to get that, but it would expand the services we could provide.
Yes.
And that would be very exciting.
Well, I can tell you it is happening, because I have a telehealth relationship with an infectious disease doctor and a dermatologist now. And those are two that are very technical.
You have a personal
I have a personal yes.
relationship. It's not a systematic thing.
Right. And I would love it to be maybe institutionalized so that all the guys that are in the shift after me, I'm a bit of a weird duck because I have these relationships, right, with other people in other settings from the Senate and what have you. But these are relationships I have with a top-notch infectious disease doctor in the state. So any patient that sees me will get a quick consult, and for free, by the way, because it's not set up properly yet, as in through the system like it
Can't
should
bill.
be. But that
So that's
means-
a very generous infectious disease
right,
doctor.
and that
doing it
person
for
is just
free.
plain terrific, and he provides a lot of extra care. And I can tell you for a fact, a lot of patients have gotten better care than I would have been able to offer myself because of this relationship.
But if he came in an hour, or your patient came in an hour after you had gone,
Yeah.
the next person might not have that relationship. They might not have access to that specialty.
Right.
And why don't we have a systematic way to do that
Right.
for the whole state?
And
It
that's
would be
something
very
you would
exciting.
recommend then?
I would definitely recommend that.
Yeah, you told me one day not long ago that only 2% of our providers are doing telehealth right now.
That's what they answered on their survey 2 years ago when they licensed.
So if that went up to 60%,
That'd be great.
we could then,
Yeah.
even though we might still have the physician shortage, so to speak, we might actually not have a care shortage of the same magnitude.
Right. We wouldn't resolve it completely, but at least could get people access to specialty care faster.
Yeah.
We also have an option in Hawaii now. We're starting a program called ECHO. Project ECHO started in New Mexico, Dr. Sanjeev Arora, and it's a teleeducation and mentoring system. So the one thing there's many things I didn't get to tell you in the solutions, but mentoring of our young providers. And this would allow for a weekly teleconference that includes case presentations, non-identified patients, so
Yes.
there's no HIPAA problems, but they discuss it with an expert panel. About 10 providers, nurse practitioners, PAs, physicians in rural areas can then develop a specialty in a certain area. He started it for hepatitis C. That's not so hard to treat anymore. So we could do it for different endocrine disorders. We could do it for behavioral health.
All right.
People could develop skills they didn't have before with a weekly hour and a half that they get CME for.
That would be great.
It's a very exciting idea. The Rural Health Association here is working to start it, and I'm very excited about having that here. It's not telemedicine.
Yes.
It's not direct patient care. We need that too.
Right. But you could increase the capacity in a doc like me to be better able to treat schizophrenia or better able to treat some infectious disease. And therefore, again, like you said earlier, people can practice at a higher level on their degree and
have a mentor.
Yes.
Have a group that they're connected to, which
Yeah.
is what I discussed before about, doctors aren't connected into the medical community as well as they used to be.
which can contribute to retention and
Right.
what have you. I think we only have a few minutes left. You're doing something pretty exceptional. You've established an annual conference now that brings a lot of the healthcare community together, maybe more than any other now in the state. Could you tell us a little bit about that?
Sure. On September 19th at the Sheraton, Waikiki, we are partnering with Hawaii Health Information Exchange that you mentioned
Yes.
earlier, as well as the State Office of Rural Health and the Hawaii State Rural Health Association. We're having the conference for healthcare providers. It's the Workforce and Health Information Technology Summit. We have 550 people registered. We're actually over capacity and we're trying to figure out what to do, but it's very exciting. It's not just for doctors, maybe half are doctors. It's for all kinds of healthcare providers. It is information on what's going on with Obamacare nationally, but also in the health information technology arena, in the behavioral health, in the Project ECHO is going to be presented there. We even have retirement and entry into practice planning options for people. So we're really trying to bring together a jam-packed one-day conference to help learn about what's going on in healthcare.
Yeah, we're so short. We realized a couple years ago we only can do it one day and we
One
do it on
day.
a weekend.
Yeah.
But I'm excited to be a part of that with you because I know that it's nice for the physician and the healthcare community to come together, but they'll be able to hear not just today from our show, but they'll be able to hear, okay, this is something that you can do to maybe recruit another young doc, but also this is something you can do to expand your capacity to give care or to expand your practice and be more efficient, or God willing, maybe someone else will hear us when we complain about the challenges to the administrative burden to get our docs freed so they can just take care of people. And all of those things, I think, really contribute to the solutions that you've been, we've been tilting at windmills together for a few years on this. And I think that people understand better and better what we're dealing with. So I'm encouraged. I'm a glass half full guy on this one. I'm encouraged that we haven't had a mass exodus of healthcare professionals.
And keep in mind, we need 50 more every year to compensate for our population and aging.
We do. So maybe that's a good place for us to kind of close. If you're watching this show and you have young people in your family that are thinking about healthcare, get them into the science track, get them interested in ultimately going through science and going to JABSOM and being a doc here. But also, if you know people on the mainland, it is a wonderful place to practice. There are a lot of incredible positives to be a physician. I can attest to personally, and I know you can too, in the state. Yes, there are challenges, but it's very rewarding to be around this particular group of people because they do appreciate you when you take care of them. Okay. So this is Josh Green. I'm the host of Healthcare in Hawaii. Today I was speaking with Dr. Kelley Withy about our physician shortage here in our state. She spoke eloquently about the 600 or 700 physicians that we're short already. That number will increase as our population ages, so we're encouraging you, please appreciate your physician, but go out there and ask people to come to the state of Hawaii, provide health care for the very wonderful residents of our state. Thanks for joining us.